In chapter 37, we'll talk about alterations in the function of the gallbladder and pancreas. So we talked about the gallbladder and pancreas as being together because they form this pancreaticobiliary system. Because the gallbladder, its duct, shares a similar duct to the pancreatic duct. And it's a controlled system where bile and pancreatic juice are both delivered to the duodenum simultaneously. Now, the gallbladder is a distensible sac, holds about 30 to 50 milliliters of bile, and the cystic duct is what connects it to the hepatic duct to form this common bile duct. So what this picture here shows is this pancreaticobiliary system. Over here in the pancreas, this is the main pancreatic duct. It converges with the common bile duct to form this hepatopancreatic ampulla of Vater, and then we have this major duodenal papilla, which has the sphincter of Oddi. And basically it helps release both bile and pancreatic juice simultaneously into the duodenum. So what this is showing here then is how, what's interesting then is that in the pancreas we have both beta cells and alpha cells, which you find in the pancreatic islets. So the pancreas has this particular endocrine function, but the pancreas also has an exocrine function in the sense that the pancreatic acini make pancreatic juice, which is basically a bicarbonate-rich alkaline solution with lots of digestive enzymes. And then those actually get dumped into the duodenum once acidic chyme enters. Now, the composition of bile is that it's mostly water, some electrolytes, and organic solutes like cholesterol. Now, bile is produced by the hepatocytes in the liver, stored in the gallbladder. Other bile components include things like bile acids, pigments, cholesterol, and phospholipids, and these all aid in the digestion of lipids. What's interesting too is that certain waste products can be incorporated into bile, like bilirubin, which is one of the breakdown products of hemoglobin, as well as different immunoglobulins, toxins, and even excess cholesterol is eliminated from your body through bile. Now, what this is showing is actually the circulation of some of the bile components. So we know that your liver can use excess cholesterol to make bile salts, and these bile salts are secreted through bile into the small intestine, basically upon digestion. Now, what we see here then is that we get reabsorption of some different substances, like some of those bile salts and cholesterol can be reabsorbed back into your bloodstream and then recycled again to be reincorporated back into bile. So it's kind of an interesting process how, although bile is incorporated into digestive contents, we still reabsorb some of those components of bile and they get basically recycled back into bile. So it's kind of cool. Now, some of this is actually lost in stool though. And for those components that are lost in stool, they actually contribute to the color of stool as well. So that if someone has a lot of bilirubin in their feces, that actually gets converted to stercobilin by bacteria, and it makes poop brown. So that some of those components aren't fully recycled, they're actually lost into feces. Now, some of the functions of the pancreas include endocrine and exocrine functions. The endocrine function of the pancreas is basically, hormones like insulin and glucagon and somatostatin are released by the pancreas, and those are involved with regulation of metabolism. Now, the exocrine function of the pancreas is which is involved with digestion. And it turns out our pancreas can make over 1 liter of digestive pancreatic juice every day. And these pancreatic juices that are made help with digestion because they contain digestive enzymes like amylases and lipases, as well as proenzymes like trypsinogen, which helps break down protein. And these are released in response to cholecystokinin and secretin. The hormones that are released by the duodenum actually stimulate the release of this pancreatic juice. Remember, during the intestinal phase of gastric secretion or activity, what we found then is that when acidic chyme entered the duodenum, that stimulated the release of cholecystokinin or CCK, as well as secretin by duodenal cells. And then once in the bloodstream, it can stimulate the release of pancreatic juice. Now, what we're going to do next is move on to talk about disorders of the gallbladder. And we'll first talk about the pathophysiology of cholesterol gallstone formation, also called cholelithiasis. Now, the majority of gallstones are just cholesterol, and think of like cholesterol salts. That's what makes up gallstones. And there's 3 main phases that actually support gallstone or cholelithiasis formation. For one, we have supersaturation. If bile contains an excessive amount of cholesterol, it can be a supersaturated solution, which means it's more likely to precipitate these cholesterol salts, which are the cholelithiasis. Now, or nucleation of crystals, like if there's a place within the gallbladder that crystals can start to form, like some sort of defect, like a scar tissue, so it makes kind of like an impurity or sort of alteration in the wall of the gallbladder, or even the existence of a cholelithiasis itself can be the nucleation center. Or even hypomotility, like if someone has low gallbladder motility, this could cause stasis of bile, and like blood, can cause clots to form. But in this case, we're talking about stones forming within bile that's hypomotile. So what this is showing then is the overlap then between supersaturation, hypomotility, and nucleation. Supersaturation is due to high cholesterol content within bile, and if it's a really high concentration, then it's going to want to precipitate onto some sort of surface. Nucleation means it's an impurity or imperfection where salts can start to precipitate and form a crystal. And then if it's hypomotile and these salts aren't removed, then that itself can also start to accumulate these crystals. So we see here then is that, like an example of like the gallbladder right here, we can start to see that gallstones can form if bile is not removed frequently enough, and under combinations of things like nucleation centers and supersaturation, that can also promote more gallstone formation. Now, gallstones can get fairly large. In fact, this is showing a gallbladder that's been transected, and you can see each one of these large structures here is a gallstone. And these gallstones or cholelithiases can be so large that they can't be passed any longer. So they can get stuck within the gallbladder, and because these gallstones act as a nucleation center, they can just get larger and larger and larger, but if they can't pass through the cystic duct, then they can't be removed. So chronic cholelithiases can lead to things like biliary colic, and this is related to intermittent obstruction of the cystic duct, and due to the lack of the release of bile, this causes persistent epigastric and right upper abdominal pain that can radiate the back. It can also lead to nausea, vomiting, and sweating due to excessive gas or flatulence formation, because if you're not releasing a lot of bile due to a blockage, then that means that bacteria will feed on the lipids in your food because you have difficulty absorbing it due to lack of bile, and this also causes fatty food intolerance. You're going to see a lot of belching, bloating, and epigastric burning from excessive gas formation. Now, cholecystitis is inflammation of the gallbladder wall. This can cause fibrosis and thickening of the gallbladder wall, and the fibrosis and thickening itself can also function as a nucleation center, which can put someone at risk for gallstone formation. And so that's why it's related to the continued presence of gallstones as well, is that if there is fibrosis and thickening of the gallbladder, that itself can function as a nucleation center, and this can cause continued presence of gallstones, which further irritate the gallbladder, which can cause further fibrosis and thickening. Now, there's two types. We have acute and chronic cholecystitis. And for acute cholecystitis, it's basically like, an acute inflammation of the gallbladder wall. And you find that in individuals with cholecystitis, they probably have cholelithiases 90% of the time. So 90% of patients with cholecystitis or gallbladder inflammation have gallstones. And it may be caused by obstruction of the cystic duct, which causes stasis of bile. And bacterial infection may also be present due to that biliary stasis. Now, with chronic cholecystitis, it's where you have chronic inflammation of the gallbladder wall. It's related to persistent low-grade irritation from gallstones and recurrent attacks of acute cholecystitis. Some predisposing factors include things like diabetes and obesity, and the clinical manifestations of this can be either asymptomatic, or you might find intermittent biliary colic and symptomatic acute attacks due to blockage of the bile ducts. Now, it can lead to a variety of complications like biliary sepsis, scarring and calcification of the gallbladder wall, which forms something called porcelain gallbladder, and this can also put someone at a higher risk for cancer. Now, we're going to move on to talk about disorders of the pancreas next, and we'll talk about pancreatitis first. Now, with acute pancreatitis, it's acute inflammation of the pancreas, where we have autodigestion of the pancreas from pancreatic enzymes. So when pancreatic enzymes leak out of the acinar cells of the pancreas, those enzymes can start to autodigest the pancreas itself, causing basically the release of additional enzymes and damage to the pancreatic tissue. Some of the predisposing factors to acute pancreatitis include things like biliary tract disease or hypertriglyceridemia. Often it's ethanol associated though. So in 66% of cases of acute pancreatitis, it's caused by alcoholism or at least excessive ethanol intake. And there's three main pathways of acute pancreatitis. It can either come from obstruction, acinar cell injury, or defective intracellular transport. But in all three of these pathways, we see the release of pancreatic enzymes that eventually cause damage to the pancreas. And so what we see here then is those three pathways. We have duct obstruction, acinar cell injury, and defective intracellular transport that causes pancreatitis. So with duct obstruction, if someone has cholelithiasis, well, these can actually lead to the blockage of the pancreatic duct, which can lead to a backup of pancreatic juice, which can lead to interstitial edema, impaired blood flow, and ischemia. And after ischemia, if these cells die after necrosis, they can release activated enzymes. And these activated enzymes can eventually lead to acute pancreatitis. Now, with acinar cell injury, this can occur in a variety of ways. It can come from alcohol in 66% of cases, other drugs, trauma, ischemia, viruses. But with this acinar cell injury, what we find here then is that due to some sort of form of injurious agent, you get the release of proenzymes into the tissue, and that once these enzymes leave the tissue, they can actually lead to pancreatitis. Or it can come from disorders of intracellular transport, where due to metabolic injury, alcohol, or duct obstruction, some of these enzymes may not be transported properly from within cells, causing intracellular activation of enzymes, which can lead to the release of activated enzymes. And you see that with all three pathways, they all lead to the release of activated enzymes. And so why is this important? Well, if the pancreas releases lipases, proteases, and nucleases, and other enzymes that break down carbohydrates, well, those are all the biomolecules that make up your cells. And so those enzymes then can start to break down the tissue of the pancreas itself. So we're going to see things like proteolysis, or basically breakdown of protein within the pancreas, fat necrosis due to the degradation of lipids within the pancreas itself, hemorrhage due to the degradation of blood vessels in the pancreas, as well as interstitial inflammation and edema from excessive amounts of tissue injury. And this itself leads to pancreatitis. Now, unfortunately, once pancreatitis starts, it's sort of a positive feedback mechanism because that inflammation causes further cell injury and more enzymes get released, which cause further injury and more inflammation. So it just kind of gets worse and worse and worse. Now, some of the clinical manifestations of acute pancreatitis include things like a steady boring pain in the epigastrum or left upper quadrant, and it's going to increase in intensity over time. You might find severe tenderness on palpation along the back, and this pain can radiate or penetrate the back. You might see this associated with things like nausea and vomiting, and abdominal distension due to the excessive inflammation from the pancreas. And one of the ways this is identifiable is actually hypoactive bowel sounds. From an excessive amount of inflammation, you might actually hear less bowel sounds in someone's abdominal cavity. And this can also lead to a low-grade fever, not from infection necessarily, but from the inflammatory response. Now, some of the complications of acute pancreatitis include things like pseudocysts, which is a collection of fluid adjacent to the pancreas. Otherwise, this can lead to things like fever, tachycardia, abdominal masses, and tenderness. And this is managed by surgical drainage of that pseudocyst or like endoscopic surgery. Now, pancreatic ascites is also a complication of pancreatitis. It's where you have leak of pancreatic fluid into the pleural space or the mediastinum. And although it's painless, this can actually lead to damage of tissues around the lungs and heart. Now, it can be detected by ultrasound or CT, or even fluid analysis attained by aspiration. Like if you're finding pancreatic enzymes in the pleural fluid or pericardial fluid, that suggests pancreatic ascites. And the treatment for this is just prolonged parenteral nutrition, as well as the placement of a stent to basically keep the pancreatic duct open. Now, with chronic pancreatitis, what we find here is that it's chronic inflammatory lesions in the pancreas that are often associated with alcohol intake, and it can progress even if alcohol consumption is stopped. Like if someone has a long history of alcohol abuse, that can progress to pancreatitis later on in their life. This often doesn't increase the risk for cancer, but it seems to be associated with things like excessive ethanol consumption, hereditary hyperparathyroidism, or even trauma, sometimes idiopathic disorders as well. And the pathogenesis of chronic pancreatitis is that we're going to see chronic inflammatory lesions in the pancreas and necrosis of exocrine parenchyma caused by and leading to fibrosis or scarring of the pancreatic tissue. This can lead to calcification, and those calcified plaques that can sort of develop in the pancreatic tissue may obstruct the flow of pancreatic juices, and that obstruction itself can lead to further pancreatitis. Now, these symptoms are really secondary to pancreatic dysfunction over weeks and months. And the clinical manifestations of this, you're going to see sort of bouts of acute pancreatitis with progressive endocrine and exocrine dysfunction. So things like diabetes may come from the loss of pancreatic islets, or malabsorption of different fat-soluble vitamins like D, E, A, and K, even weight loss from poor intake related to pain. And it can be insidious if the onset is steady, and it's often can be kind of like a boring epigastric sort of pain that may come on first, which can lead to nausea. But typically, if someone has this sort of unchecked for 5 years, this continual pain can lead to a burnout where someone actually no longer feels the pain associated with their pancreatitis. So they feel like they're better, but the damage is actually continuing. Now, some of the complications of chronic pancreatitis include things like pseudocyst and pancreatic ascites, similar to acute pancreatitis, as well as obstruction of the common bile duct, thrombosis of the portal and splenic veins from hemorrhage, or even peptic ulcer disease where pancreatic enzymes can start to digest the intestinal wall itself. Now, pancreatic cancer only accounts for about 2% of all cancers, but ranks 4th amongst cancer deaths from malignancies. So it's a very fatal form of cancer. For one, it's difficult to diagnose and treat, and the median survival rate after diagnosis is only 1 year. Some of the risk factors for pancreatic cancer, though, include cigarette smoking, obesity, and the clinical manifestations of pancreatic cancer depend on where the cancer is located. If it's in the pancreatic head, like sort of right where the pancreas meets the duodenum, this leads to jaundice due to the poor elimination of bile. And so that bilirubin ends up building up in your body's tissues rather than being eliminated through your duodenum via bile. This can also lead to malabsorption and weight loss from decreased degradation of nutrients. And if it's in the pancreatic tail, this actually is more associated with things like abdominal pain and nausea, but not necessarily a jaundice because it might not affect the elimination of bile.